Hello, my name is Dr. Daniel Reeders. In this presentation, I'm going to have three ideas I'm going to be weaving together. One is HSCRP, why measure it and what to do with it, what's its importance. Number two, about what's actually going inside the artery that is vulnerable, the vulnerable plaque, and what to do about that and how to manage that and analyze what's going on. And number three, how to shrink an arterial plaque. That's the weave. So HSCRP, high sensitivity CRP, versus the other CRP that can be measured, HSCRP is known as cardiac CRP, is a marker. So in clinical medicine, we have something called a sedimentation rate. And so with a sedimentation rate, when it's elevated or a HSCRP is elevated, or something called a GLYCA, Glyca, those represent that there's something going on in the body that's not good. So we don't treat an elevated sedimentation rate. It tells us that there's something going on and that we treat what's going on like an infection or inflammation, autoimmune cancer, so forth and so on. And then this comes down because we are successful with our treatment. So as an example, if you have a patient with an elevated HSCRP of 3.8, which is greater than 1 and greater than 2, and in ill patients, we like to get under 0.5, and their cholesterol LDL calculated, which is the common test we measure, is controlled on a statin drug, what's the follow-up? Please note that a statin can decrease your CRP. So what do you do? Where do you go? So it's CRP, HSCRP says there's a fire going, and it doesn't tell us where the fire is, and that's up to us to figure that out. And then that's what they call precision cardiology. I don't like the term because it sounds like a branding terminology. I'd rather just say it's superior or just plain good medicine. So in that patient, you'd want to do an investigation and see what's going on and why the HSCRP is up, for example. So why measure the CRP in the first place? And the fact is that it's not good enough. Well, there's studies like the Jupiter study, and it's an independent risk factor that predicts something called MACE, major adverse cardiovascular events, and cerebral vascular events, even when the cholesterol is at goal. So it correlates with future heart attacks, strokes, and death. And so even though the cholesterol is controlled, it's looking at something else and amplifying something else. It doesn't tell you where the problem is. That requires some further questions and testing or making assumptions. Sometimes when we make assumptions, we do the wrong thing. So CRP, as we're talking about, is downstream biology. To make CRP, over on the right, the liver has to produce it. And what tells the liver to produce it? Something called IL-6, interleukin 6. And what tells interleukin 6 to go up? Well, specifically two biomarkers that you can measure in the blood. Also, all of these can be measured in the blood in a commercial lab called interleukin 1B1 or TNF alpha, tumor necrosis factor alpha. That sounds pretty bad. And what tells the IL-1 beta and TNF alpha to go up? Well, something called NF kappa B, which is a master switch. And when that gets activated, then we activate this chemical cascade that produces HSCRP. So it says it's a master inflammatory transcription factor that's in the cell. It's being told to do that. So what tells the body to produce NF kappa B? Well, let's go upstream from that. Something called PAMPs, DAMPs, toll-like receptor activation, oxidative stress. So now we're getting there. So these are the messengers. So PAMPs are pathogen-associated molecular pattern, and DAMPs are damaged associated molecular patterns. So damaged chemicals, mainly in cardiac patients, produce this eventual HSCRP, although it can be PAMPs also. So, and then oxidative stress, that means damaged molecules that also are primary drivers of artery disease. So I forgot to say why this is so important. The number one killer in, let's say, America and most modern countries, except maybe if they're at war or something like that, is vulnerable plaque, soft atherogenic plaque inside the artery walls. That's the number one killer. So this is exactly the space I'm talking about. And that's why everybody needs to understand this, whether they be a patient, a cardiologist, a family doctor, any doctor, or a functional doctor. So let's dig a little deeper. So we're talking about markers. So those like the sedimentation rate or HSCRP. We're talking about mediators and we're talking about effectors. So some are amplifiers of what's going on, feeding the flames, and some actually damage the vessels in the plaque. So we have some of these listed. So some are also called acute phase reactants. They go up when there's chronic inflammation. And so those would be CRP, sed rate, fibrinogen. All kinds of markers go up in the blood when we have infections or inflammation or cancer. They're a marker that something bad is going on. Then we have mediators. They drive inflammation. And these would be interleukin 1 beta 1, TNF alpha, NF kappa B. These are the engines. Targeting them reduces events. We have studies that have shown that. So these are direct things that we want to decrease. They're more upstream and they're measurable. They just can't come back in a day or two usually. So in the hospital, we have to make assumptions about what's going on. And you need these elevated to get an HSCRP. And then interleukin 6, this is the bridge cytokine. It amplifies the signals. It connects immune activation to systemic acute phase response, closer to the driver. So we can pick this apart and figure out what's going on in a specific patient, if need be. So let's bring in one of the worst things. It's called ApoB. ApoB is the particle number. It measures the atherosclerotic food for the plaque. If you don't have any ApoB around, you do not make plaque. When you have plaque and you want to get it smaller, you starve it by decreasing the ApoB. it's more predictive than an LDLC just because it measures particle number and more particles than just the LDL. So it's more precise. It gives you more information. If you had to just run one test, an LDLC or an ApoB, to get you accurate map, accurate information, it would be ApoB. And by the way, the size of the particles matters. So if ApoB measures particle numbers, where LDLC measures the weight, when you have smaller particles in the ApoB, they can go inside the arterial wall easier. So part of clinical medicine is to increase the size of the particles, and that usually has to do with a metabolic treatment. So as a sidebar, measuring something called lipoprotein A, sometimes they measure the weight, but here again, getting the lipoprotein A particle number is more predictive than the weight. So that's something to remember. I hope I talk about this when we talk about lipoprotein A. So this is in red on the right. Pay attention. About 30% of patients that have events have LDL-C at a goal. 30%. So just having a normal, so-called normal LDL cholesterol, which is measured everywhere, it is the metric that everybody measures. There's still a 30% rate. We can do better than that. So depending on how sick the patient is, we definitely want to treat the ApoB and get it lower. It's just better medicine, more precision. And this is all in medical guidelines. So a lot of physicians feel like they need to be protected in corporations which don't like to take risks, and guidelines because they are formed on this. In fact, most of the guidelines are formed on LDL-C, not on ApoB, which is a better marker, or hsCRP. And so it's a clunky old system that's not precise, and having precision matters. So what we want to do is decrease the food for the plaque, the ApoB, and make the small numbers less and the particles smaller so they can't go in. There's something called lipoprotein A, which is independent. Lipoprotein A can cause strokes, heart attacks, death, calcified cardiac valves, and blindness through retinal vein thrombosis. So we'll talk more about that in a few. And then so that's substrate, and then we want to look at the inflammation. So inflammation is bad. It drives the system in general, and particularly inside the plaque. So we have systemic inflammation, which amplifies things, and inflammation inside the plaque. And there's a certain treatments we can use, and a lot of these treatments are based upon assuming that something called MPO, MMP9, LPLA2 are abnormal, and so we give these treatments without knowing. We're making assumptions. It's population medicine. And there's specific pharmaceuticals that treat these. So one of the thoughts is, how about if we go upstream and we get rid of the DAMPs and the PAMPs? And there's science behind this because, for instance, when they bring a new drug to market, it costs about $1 to $2 billion. So they find one of these biomarkers, like one IL-1 beta 1, and then they lower it because in a pilot study and biochemically, and then they do the study and they find out it helps. So that's how those are developed. That's a lot of money. So going upstream, you've heard in COVID about the innate immune system, and that's via something called APCs, antigen presenting cells, and other thing called toll-like receptor pathways. So two of the pathways, one is a TLR4, which measures metabolic in gut. So when someone eats food and the gut's not functioning, they leak into the bloodstream something called LPS, lipopolysaccharide, which come from the cell walls of gram-negative bacteria like E. coli, and they flood the bloodstream. And so after a meal, some people have brain fog, and this is where vessels get damaged because of these things. And the LPSs are some of the most pro-inflammatory molecules in the body. So healing a gut and eating good food, because the system sees it's being attacked by gram-negative bacilli, which are common in, for instance, urinary tract infections. And then another driver would be the fat around your organs, like something called liver fat, or around the stomach area. In obese people, the fat right around the tummy is very metabolically active. So getting rid of that is critically important. And how to do that is beyond the scope of this talk, of course. And then we control insulin resistance. That's pre-diabetes and diabetes. It's pre-diabetes and diabetes is in somewhat of a arbitrary grayscale. Any pre-diabetes or diabetes are not good for arteries. And so we can look at treating insulin resistance. And there are people that are experts at that. Now we jump over the toll-like receptors too, and we're looking at oral and periodontal access, gum health. Yes, brush only the teeth you want to keep. And the gum health, we need gum health to produce nitric oxide, which helps our arteries maintain good blood pressure to different organs and cells. And you can get a blood test called a TMAO, which can show a problem there. And you can go to a dentist and they can measure what's going on in your mouth and look at your gum health, and that can be remedied. And then that's another upstream treatment. So I put these picture in here. And what is important in an artery is that there is an inside and an outside of the artery. And then the inside of the artery is where the blood flows. And so when we have this plaque inside the artery wall, for instance, when it becomes vulnerable, just not a regular plaque, the on top of this is a cap on top of the plaque. And if this thin fibrous plaque gets thinner, that protects the plaque from entering the bloodstream, it can burst open, rupture, and that's what causes a cardiac catastrophe. And so all of these different parts of the plaque we can understand, we can get markers, which we'll talk about in a bit, and figure out how we're doing here. And if we decrease these markers, then hypothetically, patient does better. So we want to, so for instance, if you have an abscess and you want to drain the abscess, you can stick a scalpel or a needle in it and the abscess will drain and it's all good. If you did that to an artery that faces the bloodstream, that would produce a cardiac catastrophe like sudden death or heart attack. So we don't want to do that. We want the Navy SEAL approach, slow and steady. We don't drain arterial plaque like that. So what we're talking about is a vulnerable plaque, and there's features that show us that we're not doing well. They include a thin fibrous cap, a large lipid-rich necrotic core. The bigger it is, it expands. Things can happen inside of that and cause chaos and havoc. Sorry for my common language. It's just easier for me to talk the way. And then you have inflammation and infiltration of macrophages, which are a type of white blood cell. These foam cells are loaded with damaged cholesterol, the oxidized LDL, which release all kinds of other things. And there's a bunch of debris inside. You see microcalcifications, and then the artery can remodel, it can change the shape. And these are all bad signs. A misnomer in generally thought of is that when people get calcium scores, that this is the problem. And a calcium score is after the vulnerable plaque ruptures, and then it fills with calcium, fibrosis, and then calcium. And so the deed has already been done, and it's not telling us specifically what's going on with soft plaque or necrotic plaque. So, yes, it's a danger signal. No, it's not telling us what to do next specifically. So, let's get down to lipoprotein A. So, lipoprotein A is genetic. There's multiple drugs in the pipeline. Some are very near getting approved by the FDA. They lower it very low. Somewhere I read it's 6 times worse than regular cholesterol, causing heart attack, strokes, death, calcified valves, blindness, for instance. And it tends to strongly run in families. So if one person in a family is identified with this, all blood relatives, in my opinion, need to be checked. Since we're, first of all, getting drugs soon to be likely approved by the FDA that are going to be highly effective. And number two, so for instance, if you have your LDLC and you put someone on a statin drug, and let's say the LDLC goes to 70, and then you keep adding a statin drug to get it lower because you want to get it lower the better, some people think. So part of this measurement could be ApoB. And there's a rule of thumb. For instance, if your ApoB, let's call it 210, if you multiply 210 times 0.3, that would be 63. And so the LDLC measurement, 63 milligrams of these 70 would be from ApoB, and a statin drug tends to increase lipoprotein A, where a PCSK9 inhibitor would be a better choice in that situation because it lowers your lipoprotein A. So the next chart is interesting. So if you had to just say what is more predictive, what is more diagnostic of something, of a future stroke or heart attack, at the top would be ApoB. Whoa, what did I do? That was more so if you were going to measure all these and see what is more diagnostic, it would be an ApoB. If you had an ApoB, is a cheap test. So if you had one test order, an ApoB would be more helpful if that's all you had. The next importance would be a lipoprotein A. And it can change during life. I've seen it, although a lot of the dogma is that it doesn't change. Then the next valuable test would be an HSCRP. It's telling us about systemic inflammation, pathway activation. And then there's another one called a GLIS-A that, so HSCRP changes over days, and GLIS-A, GLYCA, has a big, slower change. So it's a better marker of chronic inflammation where the HSCRP is more acute. And then we get in terms of potency of prediction, a hemoglobin A1C, another inexpensive test. So is an HSCRP. And then there's things such as homocysteine, TMAO, myeloperoxidase, interleukin 6, LPPLA2, which shows plaque inflammation more specifically than an HSCRP. It's more toward the target. And then near the bottom is LDLC. All of these tests are more predictive of heart attack and strokes and can be treated and are metrics to see if we're winning or losing. One more thing is there's CTA, which are non-invasive. It's a CAT scan contrast injection that looks at the coronary arteries, and there's new technology called AI that can tell us how much soft plaque, where it is, how much hard plaque, calcified plaque, and how much necrotic plaque and where it is, and see if there's flow limiting stenosis and remodeling and those type of things to see if the patient needs a cardiac catheterization. So the cardiology field is quickly changing from ordering stress tests to everybody to getting a CT angio because it gives us more information. And I get educational material about learning more about this at least once a week from big companies. So these are going to be really good metrics. They tell us more, and they're going to rapidly change the advances in management of cardiovascular disease, in my opinion. So, what exactly are these telling us? Going back to the markers, so we have the markers, the HSCRP, the GLIS-A, the IL-6, the LDL-C, and then we're looking at amplifiers of disease. And this would be the lipoprotein A, which belongs in all of these categories, homocysteine, hemoglobin A1C, TMAO. So we want these to be, this turns down the flame and the fire and stops the fuel of the fire. And then what are the direct toxins? Well, these are ApoB, oxidized LDLs in here, down here, LPPLA2, myeloperoxidase, which is associated with oxidized LDL, which attacks the fibrous cap and the promotes this fire going on in the artery. And then we have a structural readout in this. So you can get invasive tests like an IVUS that goes inside of arteries. That's invasive. You can get a calcium score, which we talked about, which just shows where there's hard plaque and not anything about soft plaque. And then we can get this CT angiogram, like many companies like Clearly, and there are others, and they're getting more depending on which test, and new technologies coming up are being approved by insurance companies. So if you had one test to really find out what's going on inside of an artery, a CT angio with AI readout would be the way to go. The AI readouts on top of the CTA. This CT angio of the coronaries is pretty much uniformly approved by all insurance companies. Calcium scores are not. You get a calcium score with a CTA anyway. And then the AIs could be an add-on cost to the patient. So, so these billion-dollar drugs that have run to the markets have proven this hypothesis about treating biomarkers. And so these are firmly in our guidelines, all of these drugs, these pharmaceuticals. Omega 3s, I like to point out, are something that are easy to measure in blood. We get something called an omega index. And for instance, 10 to 15% of the brain is one of the omega 3s measured here called DHA. And another one is EPA, which there's a pharmaceuticals for this grade. And it's what we would, if you went, you would buy, for instance, a fish oil at one of your local stores or online. The body doesn't make these efficiently, so we need to get them from diet. We need to supplement. We need to get it in our foods. We need good food sources of these. And this is something that is all part of this whole process. And then the new drugs, the GLP-1 agonists we use for getting rid of that fat around organs and on our waistline, that metabolically active. And there's a lot of nuance and in my opinion, better GLP-1 agonists that are coming on board that help preserve the muscle and the bone, because it's not the weight loss necessarily, it's what's inside, how much muscle you want to keep muscle and bone and not lose that. Beyond the scope of this talk. So how do we make these soft plaque smaller once they're calcified, diminishing return? So we can starve it by getting the ApoBs as low as possible. We can get rid of the inflammation. And we can treat the metabolic health, and we can measure it with CT angiograms. Those are radiation, so we don't want to do too many of those. But getting a really solid marker of where we are really helps cardiologists manage their patients. So I don't really like this "what do we do on Monday morning" thought, but a lot of people say that. If we have an elevated HSCRP, we repeat it. We look for ruling out systemic inflammation, and then we say, oh my God, there's a problem. Oh, sorry about that languaging. I apologize for that. That doesn't belong in a lecture. We rule out other problems. We figure out what's going on. We start being a little more scientific about this, and we evaluate for metabolic drivers. And then we look at the mouth and the gut, send people to the dentist, make sure they're doing brushing the gums and the teeth and the water pick type device. And then if there's red flags, if you have an elevated test like a MPO or a MMP9, which is really hard to get ordered anymore. Up to a year ago, it was easy to get. And LPPLA2, those would be, or a CT angio, which shows a thin fibrous cap, and a lot of necrotic plaque, particularly in dangerous places in the coronary artery tree, that would be someone that we'd like to act on. By the way, people that get stents and bypasses do better when we treat the underlying process because they're just bypassing the problem or dealing with it that way. They're not dealing with the underlying process that's driving this in the big picture. And we don't like people coming back for multiple stents and stents after bypass. So in a funny way, a CRP tells you it's a smoke alarm. ApoB and LPA are like, they're the one that's feeding no ApoB, no lipoprotein A, no plaque formation. So the lower we get plaque regression. And then if a vulnerable plaque is created, then we can assess this with these various biomarkers and get aggressive. Because a lot of heart attacks occur in patients who have less than a 50% stenosis, and they are told after a coronary angiogram there's nothing to be done, and because they're not assessing vulnerable plaque per se, although you can see things on coronary angiogram such as remodeling, you can see it also on a CTA. And so we don't want to say, oh, you can even have a normal coronary angiogram or minimal obstructive disease, non-obstructive disease, and have serious vulnerable plaque going on. So we don't want to have our patient present from a 20% plaque that ruptures, having a blood clot form out and include the vessel, or have a heart attack, stroke, or heart attack, depending on where it is. Oh, we would want to know that because sometimes people don't survive these catastrophes. So like a 20, 30%, 40%, 50% obstruction of a coronary artery would not cause symptoms. You'd get a negative stress test. But so you haven't really known if you have vulnerable plaque or not. You don't know. So that's why ordering an ApoB and HSCRP would be very minimal things that would need to be done. So it's just not an unlucky patient. We have tools. So this talk was meant to weave together 3 different concepts about HSCRP, why order it, and what to do with it when it's elevated. We answered those questions to weave in the question of what's actually going on in the artery, and particularly if we're having a vulnerable necrotic plaque, we can identify that now. And the third part is if we do have plaque that is necrotic or just not, extensive, we can actually shrink these plaques. There's strategies for that. So these 3 points were weaved through this. My name was Dr. Daniel Reeders.